Hi guys, welcome back. This is Dr. Praveen Jaswal from Hinduja Hospital, Mumbai. In today's video, we'll discuss the basics of color Doppler for the students and freshers in radiology, how this Doppler is done, what are the basics, the machinery, the knobbing, and the indications and the minute details. So there are two types of Doppler we are using. One is called pulse wave or P wave Doppler, which is used for all kind of abdomen and limb Doppler studies. And another one is called continuous wave or C wave Doppler, which is used for echocardiography. So what is the difference between the pulse wave Doppler and continuous wave Doppler? The difference lies in the transducer. In continuous wave Doppler, the sound is emitted by the transducer, it hits the target and receives the signal continuously. There is no time gap between the emission of the sound wave and receiving the signal. Whereas in case of pulse wave Doppler, the sound wave is emitted by the transducer and it hits the target, the RBC in the moving blood, and then the signal is received after a few milliseconds, and then another signal is emitted. So because the signal is emitted one by one, it is called a pulse wave Doppler. And how this is done? See, this is a pulse wave transducer. So sound wave is emitted by this transducer, which hits the target, which is the blood vessel, and RBC is moving from this point to here. And when the RBC reaches here, the signal is received by the same transducer after a few milliseconds, and the distance covered by this RBC in that particular time difference, we can determine the velocity of the moving RBC, the blood inside the vessel. That is the reason in our radiology practice we use pulse wave transducer, whereas in case of echocardiography the continuous wave Doppler is used because they don't need the velocity part. What are the indications of Doppler study? Doppler study is done for many arterial and venous systems. For arterial system, one indication is carotid Doppler, which is done to see for any plaque and causing any stenosis or occlusion. And the same thing is done for upper or lower limb arterial Doppler also. And for the venous system, it is done for deep vein thrombosis or varicose veins. Doppler is also done in upper limb for arteriovenous fistula before the surgery, and after the surgery sometimes it is also done to see the patency of the fistula. Renal Doppler is done to rule out any cause of renal hypertension and also to rule out any medical renal disease. And the same indication is also for the transplant kidneys to see for any acute or chronic rejection or thrombosis. Fetal Doppler is very popular nowadays to rule out any uteroplacental insufficiency. And other indications in abdomen are portal hypertension, mesenteric ischemia, also in cases of ovarian torsion in females, and to rule out testicular torsion, acute epididymitis or varicose in male patients. And color flow imaging is also used in cases of female infertility to see the flow at the endometrial bed of the uterus. So before going further into the minute details, we need to learn a few terminologies used in Doppler study and also the keyboards on the Doppler machine. So some of the terminologies are color flow imaging, Doppler spectral waveform, gating, steering, pulse repeating frequency or scale, aliasing, and angle of incidence. We'll discuss one by one. So when you start the examination, there is a key on your machine which is called CFI or color flow imaging. So when you put it on, a box appears in your field of view which should cover the vessel which has to be examined, and the size of the box should be optimum. It should not be very big or very small. So when you put on the color flow imaging, the box will appear and the vessel will start showing different colors. So if the blood flow is towards the transducer, it will show red color, and if it's away from the transducer, it will show blue color. It has nothing to do with arteries or veins. Any blood flow which is towards the transducer, whether it is artery or vein, will start showing red color, and if it's going away, it will start showing blue color. But in the protocol, we show the arteries in red color and veins in blue color. So we'll have to adjust the color flow imaging as per the protocol. We'll put red color in the arteries and the blue color in the veins. So when you put on the PW key, that is pulse wave Doppler, on your machine, a gate will appear on your screen. The gate should be put in the center of the vessel, and the size of the gate should be according to the size of the artery concerned. Another very important point is steering. When the box appears on the screen, you should follow the direction of the artery concerned. So this is internal carotid artery, which is flowing from right to the left side, from superficial to deep. So now the box will have to be in the direction of the internal carotid artery flow. So the apex is turned posteriorly on the deeper side from right to left, and in this case, when we are seeing the common carotid artery which is flowing from right to left but from deep to superficial. So now the apex has turned to the right side superiorly. Steering is very important, otherwise the color flow will not appear good on your screen and the spectral waveform will not be so sharp. Pulse repeating frequency PRF or scale is another knob on your machine which should be used according to the vessel you are examining. Like if you are doing arterial system, suppose you are doing carotid Doppler, then the velocity of the carotid artery is almost 60-70 centimeter per second. So in that particular case, you will have to put your PRF between 50 to 80 or 100. Similarly, if you are doing a venous examination which has a velocity around 15 to 20 centimeter per second, in that case you will have to put your PRF between 5 to 20. If your PRF is not properly put, then there will be aliasing. And what is this aliasing on color flow imaging? See, this is a smooth single color vessel showing blue. And here at the site of the branching of the vessel, you are seeing mixing of the color. So this aliasing can occur in 3 points. One, when the PRF is not particularly set according to the flow velocity of the vessel, and if there is any branching pattern of the artery, and also if there is any stenosis, it will show aliasing, which shows a turbulence. So basically aliasing shows the turbulence in the blood flow in cases of branching, in cases of stenosis, and also if the PRF is not properly set. When the color appears on your screen, you put another key which is PW, pulse wave Doppler. Then the concerned artery will start showing you spectral waveform. So what is this spectral waveform? Waveform is, this is start of the wave and this is the peak systolic point, and then it comes down, which is the end diastolic time. So height of this peak stole shows you peak systolic velocity, and this is called end diastolic velocity. Now coming to the spectrum formation. How this spectrum is formed according to the RBC flowing in the vessel. So see, this is a vessel and there are RBC flowing in different capacities. The central one has a very high velocity, whereas the peripheral have the lesser velocity. So if you see the same effect on the spectrum, the central one will show more velocity and the peripheral will show less velocity. So this is the spectrum which shows different velocity of different RBC in different position inside the vessel. Basically, there are three types of spectral waveforms. One is triphasic, biphasic, and monophasic. In triphasic one, there is a systole which comes back to the baseline. Then there is a reverse diastole which again comes to the baseline. So systole, reversal, and again to the baseline is a triphasic. In biphasic, there is a systole and there is a long diastole. So there is no reversal. And in monophasic, there is only a systolic component. There won't be any diastolic component. So basically, the triphasic and monophasic shows a high peripheral resistance, and the biphasic shows a low peripheral resistance. If you see, every major artery of the human body show a typical spectral waveform signature. Like this is a superficial femoral artery. It is showing a peak systolic velocity coming back to the baseline, and there is a reversal of the diastole. So this kind of pattern, which is a triphasic pattern, is shown in all limb arteries, lower limb or upper limbs, because it's a high peripheral resistance in the periphery of the limbs. Whereas the central arteries like common carotid artery or internal carotid artery will show a biphasic pattern with a systolic and a diastolic component, and external carotid artery, which is again a peripheral artery, will show a triphasic pattern. So triphasic patterns means there is an increased peripheral resistance, and the biphasic waveform shows there is a low peripheral resistance, which is shown also in the umbilical artery. Normal umbilical artery shows a biphasic pattern with a systolic and a high diastolic component, but when there is an increased peripheral resistance, the diastolic component will go away and there is a monophasic form or reversal of diastole showing a triphasic kind of appearance. So increased peripheral resistance is a sign which is seen in all peripheral arteries, and presence of diastolic component shows a low resistance pattern. Angle of inclination is very important to determine the exact velocity of the RBC flowing in the artery. See, this is a transducer which has kept in right angle to the artery. So it is emitting the sound wave and receiving at the same angle. So it won't be able to detect the flow of RBC from one point to here. But if the angle of the transducer is changed, now it can receive the RBC, the signal from the RBC from here to here. The distance covered by this RBC can be easily detected. So ideally, the angle of the transducer should be parallel to the vessel, which is almost impossible to get into. But ideally, it should be kept as less as possible. So below 60 degree is the optimum one. If it is 20, 30 or 40, it will be more accurate. But if it is more than 60, then the accuracy will be very less. It is very interesting to know that the Doppler physics and car driving on a road are almost similar. So like suppose this is a road and the traffic is moving. The car which is on the outer side will have a good velocity, whereas the car which are on the inner aspect of the road will have a slow velocity and turbulent flow. Similarly, at the branching of the road, there will be more turbulence and slower velocity on the inner aspect. And when you drive the car, you need a steering at the turnings. Similarly, we use steering when the blood flow direction is changing according to the when you are doing on the color flow imaging. Similarly, like on car driving, when you need to drive at a higher speed, we need a third or fourth gear for velocity around 70-80 km per hour. But if you are driving at a low speed, I mean 30-20 km, you need a second and first gear. Similarly, we need in arterial flow, we need a high PRF, and in case of venous flow, which is a slower one, we need a low PRF. So PRF is a kind of accelerator what we use in car driving. So steering, PRF, accelerator, and the direction of the flow and the turbulence, everything is analogous. The same pattern you can follow in these four images. So this is a road which is some congestion over here. So the traffic which is moving on one side of the road on the outer side will have a smooth flow, and on the right side will have a turbulent flow. And if the congestion is from both sides, then the central one will have a good flow, and the peripheral one, this one, because the more congestion is on the right side, so it will show turbulent flow. And if there is a severe congestion as a bottleneck, then the traffic which is moving centrally will speed up when it comes out. So that is the basic pattern which we use in determining the velocity and the percent of stenosis. We'll discuss later on, and how this is shown on the spectral waveform. So this is a normal waveform, a smooth peak, a sharp peak of the peak systole. But when there is a turbulent flow, the spectral peak will show widening. This is called spectral widening. So spectral widening denotes that this is also spectral widening, and this is a complete spectral widening. So this denotes stenosis if the vessel is straight. So spectral broadening or spectral widening is another important point which denotes stenosis. So what are the signs of stenosis in a blood vessel? Increase in peak systolic velocity and increase in end diastolic velocity. Then there is spectral broadening, which I have shown, aliasing I have shown earlier. And if you listen to the sound which comes out through the speaker, there will be a very sharp, shrill sound in case of increased PSV and spectral broadening in cases of stenosis. So these are 4 signs of stenosis. And how to calculate the area stenosis? There are 2 methods. One is by drawing by the cursor on the gray scale or color flow imaging. On the transverse image, you put cursor at the remaining lumen of the artery and the area of the plaque, and with the software on your machine, it will tell you the area, percent of area stenosis. But this is not very accurate. The most accurate part is by the Doppler velocity calculation. And how it is done? We record the velocity at different levels in the artery, and suppose V1 is the velocity just proximal to the site of stenosis and V2 is the velocity just after the site of stenosis, then the percent of area stenosis will be calculated as 100 into 1 minus V1 by V2. Like if V1 is 100 centimeter and V2 is 400 centimeter, then the percent of area stenosis will be 75%. So by this formula, but grossly we should remember that if the V2 is less than double of the V1, then the percent of stenosis will be less than 49%, which is mild. And if V2 is more than double, then it will be, area stenosis will be more than 50%, which is moderate. And if V2 is more than 3.3 times, then the area stenosis will be more than 70%. So you need to remember this one. If the velocity is double, more than double, then it is a moderate. If it's less than double, then it's mild. And if it's more than 3.3 times, then it's a severe stenosis. And for reporting, we use the same format: 0 to 49% as mild stenosis, 50 to 69% as moderate stenosis, and more than 70%, less than 99% is a severe stenosis. And if it's 100%, then we report it as a complete occlusion. Till now we have learned about the calculation of the percent of area stenosis in the arteries. Another important aspect of the Doppler is to study the peripheral resistance, which is used in cases of renal parenchymal disease. When you are doing a renal Doppler study, increased resistance in the peripheral arteries shows early renal parenchymal disease, which is also used in cases of renal transplant Doppler as a sign of early rejection. And vastly it is used in fetal Doppler studies for uteroplacental insufficiency. And this high resistance pattern can be appreciated by looking at the spectral waveform. A high diastolic component shows a low resistance pattern, and absence of diastole or reverse of the diastole shows a high resistance pattern. And for this quantitative analysis of the peripheral resistance, we have three indices. One is SD ratio, which is systolic by diastolic ratio, S by D. So suppose this is a spectrum, then this peak systolic velocity will be S, and this end diastolic velocity will be B. So A by B is a normal SD ratio. Similarly, there is another index which is pulsality index, PI index. The formula is A minus B divided by the mean of A and B. And the resistive index, which is RI, the formula is A minus B divided by A. So there are three cutoffs for in every, whether you are doing a renal study or a fetal study, in both the cases the cutoff is, for SD ratio cutoff is 3.3, for PI cutoff is 1.1, and for RI the cutoff is 0.7. Just remember this one. And in renal Doppler, we preferably use the resistive index, which is 0.7 is the cutoff. It's more than 0.7, that's a high resistance flow, and if it's a less than 0.7, that's a normal one. And PI is basically used, PI and SD are used in cases of fetal Doppler. So if the PI is more than 1.1, then is a high resistance flow, less than 1.1 is a normal, and similarly the SD ratio is, if it's more than 3.3, then it's a high resistance, and if it's less than 3.3, then it's a normal flow. So these three indices are used for quantitative analysis of your peripheral resistance. So in this video we have learned about the basics of the Doppler, but before finishing it, you must remember the basic protocol and the convention, what we use during our reporting and imaging. So when you are giving the images, always be sure that the arterial flow should be shown in red color and the venous flow should be shown in blue color. You should never show the venous in arterial in red color and the arterial in blue color. Similarly, in your waveform studies, the arterial flow should be shown above the baseline and the venous flow should be shown below the baseline. And it should not be reversed. You must remember that. So that's all about the Doppler. Thank you very much for joining. I hope this will help you in your day-to-day practice. Thanks again. Bye.